And beyond the cutoff, there are various issues with selection of TMB as a biomarker. One, the platform used. We know we use whole exome sequencing as the gold standard, but for clinical purposes, we use targeted NGS panels. And these panels vary. There's variation from platform to platform used. The panel size has to be at least 1 to 1.5 megabase to be able to call out TMB. The gene content matters because these targeted NGS panels are biased towards somatic mutations. The genes that are recurrently that have higher rates of somatic mutations. So we have to take that into account, not to overestimate TMB. The type of alterations measured varies from assay to assay. So non-synonymous mutation are the sine qua non alteration that are associated with TMB, but then other assays, for example, Foundation 1 also measures synonymous mutation and indels, whereas NSK impact does not. The need for a matched normal sample to be able to call out, exclude the germline variants. And if you don't do that, you have to use a bioinformatic algorithm to be able to do that. So, for example, the match normal is, we do have match normal for MSK impact, but not Foundation 1. And obviously, the match normal will also simplify your life because you would be able to exclude the contribution of clonal hematopoiesis, particularly if the tumor is infiltrated with blood cell, let's say. Also, there are some issues with purity of tumor sample, artifacts related to frozen formalin fixed paraffin embedded tissue, classically the C2T artifact. What about blood-based TMB? Does that overcome the limitation of tissue-based TMB? No, well, not quite. I mean, we had tons of retrospective analyses that were done, particularly in non-small cell lung cancer, showing an association between outcome and immunotherapy with use of blood-based TMB using various assays, various cutoffs, and the most common one used was 16 mutation per megabase, again, arbitrarily because it tended to correlate with the cutoff of 10 mutation per megabase in tissue. So blood-based TMB of 16 correlated with tissue TMB of 10 mutation per megabase, the cutoff. So, but when we prospectively tried to look at this as a biomarker in the BFAST study, in the cohort C of the study, they took patients with non-small cell lung cancer, first line, and they selected them based on at least a blood TMB of at least 10. And they randomized these patients to atezolizumab versus platinum doublet. And when looking at the efficacy, the primary endpoint was PFS in patients with blood tumor mutational burden of at least 16, which is, again, because it correlated with that cutoff of 10 in tissue. We see no difference in PFS and OS. So is it, again, the same issue with tissue? Is it histology? Because they see an association with non-squamous, but not for squamous cell carcinoma of the lung? Or is it maybe the cutoff? Because when they revise the data and try to look for the optimal cutoff, it seemed that blood tumor mutational burden of more than 20 was the one that had the strongest association with hazard ratio of 0.59 for PFS. So no better than tissue tumor mutation burden. So I think in this area, we haven't really had a success when it comes to that tumor agnostic approval. So moving on, we're going to touch base on the 3 tumor agnostic approval for targeted therapy in oncology. So I covered the 3 in immunology, immunotherapy, and now targeted therapy. And I think everyone is aware of, the NTRK fusions, NTRK inhibitors. NTRK fusions are oncogenic. Their prevalence varies from tumor to tumor. We have very high prevalence for some tumors, such as MASC or secretory breast cancer, and some infantile tumors, infantile fibrosarcoma and mesoplastic nephroma. Intermediate prevalence between 5 to 25% for some tumors, such as GIST, split tumor, or thyroid cancer. And for some pediatric gliomas, that would fall in the intermediate category because they tend to occur much higher in high-grade gliomas in the pediatric population compared to the adult population, and a very low prevalence for the rest of the tumors. So the most solid tumors, as well as hematological malignancy, would be less than 5%. The way that we detect them is use NGS panel primarily. Only for the very high prevalence tumor, we can use IHC to be able to see whether it's positive. If it's positive, we don't need to confirm that with an NGS panel, but with the lower prevalence, the positive predictive value decreases, false positive increases. So for lower prevalence tumors, you can't really use IHC. RNA-based NGS assay are superior to DNA-based NGS assay. They tend to be more sensitive and more specific because of, they can detect all fusion partner. It doesn't matter what the breakpoint is, what intronic sequence it occurs. And it's also able to detect whether that fusion actually causes a functional transcript or not, which DNA NGS is not able to do. It seems like liquid biopsy may be also a valid way to test for those. There was a study this past year showing a high concordance between liquid and tissue detection for these fusions. And so we have two TRK inhibitors that are approved. One was approved 2018 and 19, so larotrectinib and entrectinib. And NTRK fusion positive solid tumors, and the efficacy data leading to approval for both of these drugs was based on pooled analysis from 3 trials for each of these agents, enrolling approximately the same number of patients, 55 for larotrectinib and 54 for entrectinib. And the overall response rate for larotrectinib was 75% with a CR rate of 13% and a response rate of 57% with CR rate of 7% for entrectinib. Again, the PFS was also different between these two agents, with a median PFS of 29.4 months for larotrectinib versus 13.8 months for entrectinib. Now, if you think about it, maybe larotrectinib looks like it's more effective than entrectinib. Bear in mind that the larotrectinib and entrectinib trials enroll different patient populations. So, for instance, in the entrectinib trial, you had a higher proportion of patients with CNS metastasis. These tend to have worse response and worse outcome. And there was much less patients with pediatric tumors compared to the larotrectinib arm. So the trials, the larotrectinib trials having pediatric tumors, these tend to have dramatic responses to the NTRK inhibitor and more improved outcomes. So this may have led to this huge difference in PFS. Also, the choice, how to measure the overall response rate was different. This was blinded independent central review for entrectinib versus investigator assessed response for larotrectinib. So it may have caused a discrepancy in response rate. And the CNS activity, at least for entrectinib, seems to be more compelling. Entrectinib, by speaking, spiritual, it's not a protein substrate, so it tends to go in the CNS and remain in the CNS, not moved out of the CNS. And if we look at the data on CNS metastasis, we have a lot more patients with CNS metastasis in the entrectinib trial compared to only 12 patients with CNS mets, not primary CNS tumor with larotrectinib. And the intracranial response rate was 69%. Patients in entrectinib for CNS metastasis patients versus about 25% for patients who have in the larotrectinib trial. There's no head-to-head comparison beyond, the CNS activity, being more compelling for entrectinib, matched adjusted indirect comparison seems to suggest that larotrectinib is better than entrectinib. However, the limitation is that the trial, how the trial was conducted and the selection of population, it cannot be overcome when you do these kind of analyses. So what about resistance? So, we see great responses, we see impressive PFS data, but invariably resistance is going to happen. So resistance occur commonly through secondary kinase domain mutation, what we know as on-target mutation. These are solvent front, gatekeeper residue mutation, or mutations in XDFG activation loop motifs. Resistance can also occur less commonly through activation of bypass downstream signaling involving activation of kinase signaling through various mechanisms. Could be BRAF mutation, KRAS mutation, MET amplification, among others. What is interesting, for example, in the study, in NTRK fusion positive colorectal cancer tends to occur in BRAF wild type and KRAS wild type colorectal cancer as determined at the time of diagnosis. And so, for example, in that study, they determined that acquired resistance colorectal cancer was occurred via KRAS and acquired KRAS mutation. And so, for example, for colorectal cancer, you may have a KRAS mutation that you didn't detect upon the time of diagnosis that happened throughout treatment. And when you treat with the TRK fusion inhibitor, the TRK inhibitor, you probably will get less response because of that existence, that mutation. But it's probably underreported because a lot of these studies that have looked at TRK fusion positive colorectal cancer and looked at the coexisting alteration were done at the time of diagnosis using archival tissue. So the second generation TRK inhibitor, repotrectinib and selitrectinib, were developed to overcome some of the resistance mechanism. They don't overcome the activation bypass signaling, but they do overcome some of the kinase domain mutations. So the on-target resistant, particularly solvent front and gatekeeper mutation, but they cannot overcome the mutation in the activation loop motifs that would require type 2 TRK inhibitor, which would be active even in the DFG out inactive state of the kinase. So when we look at, for example, repotrectinib, which was designed to overcome, some of the on-target resistance, and this was looked at in the Trident-1 phase 2 study and looking at the expansion cohort 6, which enrolled patients who are TRK fusion positive and were previously treated with a TRK inhibitor and had progressed. We tend to see an overall response rate of 48% and even higher response rate in patients with solvent front mutation. And these occurred about 57% patient in that expansion cohort. So they tend to be quite prevalent. Obviously, cannot overcome bypass pathway activation and XDFG motif mutations. The second tumor agnostic approval is for BRAF mutation. It was BRAF combination of dabrafenib and trametinib, which was initially approved for anaplastic thyroid cancer, non-small cell lung cancer, and melanoma. But the tumor agnostic FDA approval in June 2022 was for all solid tumors except for colorectal cancer, was based on a basket trial, the NCI match study, the ROR, BRF-11701, which is ROR study, and as well as a small population of pediatric patients with low and high-grade gliomas. So in the NCI match study, which enrolled solid tumors, leukemia, lymphoma, and myeloma, excluding melanoma and thyroid and later lung cancer, we see compelling overall response rate, PFS, and survival data. In the ROR basket trial, we'll also see compelling data for biliary tract cancer, with a response rate that is impressive and median overall survival that is also compelling. In the glioma cohort, also impressive activity in the high-grade glioma, overall response rate 31%, and a median overall survival 17.6 months, including 13.7 months for patients with GBM. And just to give you that perspective, cytotoxic chemotherapy, we're not even able to achieve 10% response rate in high-grade glioma. So that is very compelling data. And in low-grade glioma, the response rate was even higher. What about other histologies? In the MATCH trial, there were 5 patients with low-grade serous ovarian cancer, and there was impressive activity as well as durable activity for these patients. This was also substantiated in other case series, showing that, if you find these mutations, low-grade serous ovarian cancer, you have durable, impressive activity and durable responses. What about non-biliary tract GI cancers, such as GI neuroendocrine tumors, particularly colorectal neuroendocrine tumors, because these are enriched in these types of mutation, or pancreatic cancer? We don't have partial responses reported in the MATCH study, but very limited number of patients. You can't really make much of that. Few case reports. So we're not really sure that the efficacy that we saw for biliary tract cancer extends to these other tumors as well. What about hematological malignancy? We know that BRAF mutation is extremely common in hairy cell leukemia. About close to 90 to 100% of patients have these mutations. And this was looked at in the ROR study, the cohort of patients with hairy cell leukemia that had relapsed refractory disease. And the response rate was really impressive, and a CR rate was 65%. And more importantly, these responses were durable. The same cannot be said about the combination of encorafenib and binimetinib in relapsed refractory multiple myeloma. The prevalence of these alterations less common in multiple myeloma, but tends to increase when you have relapsed refractory disease and is associated with poor prognosis. So in that Burma study where they looked at that combination, that setting, in patients harboring this mutation, we've seen a very high response rate. However, the response was not durable, and the resistance occurred quickly, and it was driven by RAS alteration and BRAF alterations. So histology matters. Response rate may be high, but it doesn't mean anything if the response is short when you're talking about tumor agnostic indication.